Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine. And I'm back with another interesting head and neck case of the day. So just like always, I want to make a statement up front that all of the educational content found within this talk has been completely de-identified in order to protect patient privacy. Okay, so the history on this case is a patient with AML who came in with facial pain. Okay, so again, acute myelogenous leukemia and facial pain, and we have 4 images to look at this time. Image on the left is an axial non-contrast CT. Image in second to the left is a coronal non-contrast enhanced CT. Third one over is the axial T1 post-contrast fat-saturated sequence of the MRI, and the image on the right is the coronal T1 post-contrast fat-saturated MRI sequence. So keep in mind that history, AML and facial pain. Look at these images. Try to put together what you think is going on here. Okay, so keeping those images in mind and that history of AML and facial pain, what findings do you see? What's the diagnosis? And importantly, what's the next step for this patient? So let's dig into the imaging. First up, we have our axial non-contrast CT. And you can see immediately that we've got some right-sided proptosis, and that's denoted here by the yellow arrow. Now, when you look carefully, you'll also see that we have some preseptal edema. And if you look even more carefully, you'll see that that retroorbital fat is just a little wispy and strandy. So we have some sort of edema or infiltration of that retroorbital fat. Whenever you see that kind of infectious appearance of the orbits, take a look at the adjacent sinuses. And in this case, we can see that we've got ethmoid sinus opacification as well as some layering fluid within the posterior ethmoid air cells. As we take a look at our coronal non-contrast CT image, we can see that retroorbital edema or inflammation right where that yellow arrow is pointing. If you compare it to the contralateral or left-sided retroorbital fat, the left side is nice and jet black. On the right, it's kind of misty and strandy, and that's really worrisome in this patient. If you look at the extraocular muscles, particularly I've pointed out the inferior and medial rectus muscles here, we can see that they're thickened and edematous compared to the contralateral side. And again, we see that inflammatory paranasal sinus mucosal disease as well. So whenever you've got that history of someone with AML, facial pain, we're seeing these kind of findings, what's your next step? And the next step is you really need to get on the phone immediately before you even finish dictating the case and have a conversation, a very frank conversation with your referring doc. In this case, they wanted to pursue an MRI. I'll kind of withhold the actual history for a couple more slides so we can go over the MRI findings. So as I take a look at our axial T1 post-contrast fat-saturated sequence, we can see right where that yellow arrow is pointing, we've got loss of contrast enhancement of the ethmoid sinus mucosa. So ordinarily, our paranasal sinuses, the mucosa within them enhances like gangbusters. That's how really the best way you can tell whether or not you're looking at a post-contrast sequence is to look at the sinonasal mucosa because it should enhance avidly. In this case, we have an area that's non-enhancing, and that is incredibly, incredibly worrisome in this case. You can also see we have that infiltrating soft tissue or strandy enhancement involving the preseptal and periorbital soft tissues denoted here with the yellow arrows, and also that retroorbital infiltration as well that we saw in the CT. As we take a look at the coronal T1 post-contrast fat-saturated sequence, again, we see that area of non-enhancement of that ethmoid sinus mucosa, a very worrisome finding. We also see that infiltration of the retroorbital soft tissues and the thickened extraocular muscles like we talked about on the CT. So this is a nice example of why we want to fat saturate our post-contrast sequences because it helps us to see what's enhancing. It's really critical to use fat saturation on your post-contrast T1 weighted imaging, but not on your pre-contrast T1 weighted imaging. So what's our diagnosis? And what's the next step? So this is a patient who had acute invasive fungal rhinosinusitis, and this is a rapidly progressive, and by rapidly progressive I mean even within hours, but it's a rapidly progressive transmucosal fungal sinus infection. This typically occurs in immunocompromised patients, and more specifically within neutropenic patients or patients who are functionally neutropenic, like diabetics. So we may not see a lot of true neutropenic patients, but we certainly see a lot of diabetics, and you always have to keep in mind, could they be functionally neutropenic and be someone who's presenting with acute invasive fungal rhinosinusitis? And it's called that because the fungal hyphae actually invade those mucosal blood vessels, and that leads to tissue infarction, areas of dry gangrene. That's what we see with the non-enhancement on the MRI. In addition to the vascular invasion, it also can invade bone, the surrounding soft tissues, including extension into the orbits, and also there's that critical possibility of intracranial extension or possibly extension back to the cavernous sinuses. We see that from time to time as well. And this is, as I've hopefully tried to make the case for so far, but I'll say it again, this is absolutely an emergency. You need to be having a conversation with a referring doc before you ever finish dictating the study. This is one that you don't let the sun go down on. You don't delay any time whatsoever in handing off these critical findings. So acute invasive fungal rhinosinusitis, it can be fatal within hours. It's been reported that mortality may be somewhere in the order of 50 to 80% of the time in these patients. And if you have orbital extension, like this case had, or if there's intracranial involvement, that predicts a really poor outcome as well for these patients. In terms of treatment, these patients will end up getting radical debridement until they reach normal vitalized tissues. They'll also hit them hard with antifungal agents. Radiology plays a critical role, not just in making this diagnosis or drawing the concern for it, at least up front, but also in helping to provide a framework, a surgical roadmap. And that's done best with MRI. Now, it's important to keep in mind, we don't want to delay their surgical management in order to get an MRI. So we're not going to sit on these patients overnight, do the MRI the next day. MRI can be very helpful, especially if it can be done expeditiously, but you don't want to delay that definitive surgical management in order to get an MRI. So there was a nice paper published by the folks at the University of Florida that looked at CT in terms of predictive modeling for trying to decide whether or not patients have acute invasive fungal rhinosinusitis. And they came up with a 7-variable model based just on the CT findings. And that's to look at specific areas that include the periantral fat, so premaxillary, retromaxillary fat, areas of bone dehiscence, orbital invasion, nasal septal ulceration, involvement of the pterygopalatine fossa, the nasolacrimal duct, or the lacrimal sac. If you have an abnormality in one of those locations or of one of those variables, you've got a 95% sensitivity for making this diagnosis and 86% specificity. And as you can see, almost 90% with positive predictive value and 95% negative predictive value. So very reliable just with one variable alone. If you have abnormality in 2 of those variables, we're talking about 100% specificity and 100% positive predictive value with a reasonable sensitivity as well. So the take-home point here is that CT is a very, very valuable screening tool for making this diagnosis of acute invasive fungal rhinosinusitis. You just need to know what you're looking for and where to look for it. And here's the reference to that paper, again by the folks from the University of Florida, Ilana Schmalfus and Tony Mancuso's group. And it's absolutely worth checking out. If you're a resident, if you're a fellow, if you happen to read any neuroradiology studies, this is a paper to know about and know what to look for with these findings. Okay, so let's wrap this up. Again, this was a patient who had acute invasive fungal rhinosinusitis. In terms of the key imaging features of this case on CT, you're looking for that sinus mucosal thickening or opacification, may or may not have bone erosion or rarefaction. But one of the really critical things to look for is that soft tissue where it's not supposed to be. In this case, we saw it within the orbit. You can see it within the preantral, the retroantral fat. We talked about all of those 7 variable places to look. On MRI, again, you may see that mucosal thickening or opacification of the sinus, a very nonspecific finding by itself. But things that get you really worried are when you see that soft tissue where it's not supposed to be, and also that loss of contrast enhancement of the sinus mucosa, that dry gangrene that's setting in. I want to stress to you, as I have already, but I'll say it again, Never, ever, ever, ever let the sun go down on these patients with potential acute invasive fungal rhinosinusitis. If you're doing third shift, you're reading inpatient studies overnight or ER patients overnight, and someone comes in with a sinus CT, absolutely put eyes on it. Make sure they don't have acute invasive fungal rhinosinusitis. And as I said, if you see these findings that are suggestive of it, before you ever sit down to dictate, get on the phone, communicate those findings right out of the gate to the referring doc, because these patients need urgent surgical debridement, and they may, for surgical planning, end up needing an MRI if it can be done as quick as possible. But I want to stress, patients can die. Patients oftentimes die of this diagnosis, and they can die within hours. So early intervention is absolutely critical in these patients. As always, I'd like to thank you for joining in with IU Radiology Case of the Day. You can follow along on Twitter at NAKuntz, and I would also invite you to check out our complete collection of IU Case of the Day materials that can be found at radtf.iuhealth.org/COTD. Thank you.